Hello everyone and welcome to Off the Cuff, and we are continuing our series on pharmaceutical advancements with Dr. Sahar Swidan. Once again, welcome to Off the Cuff.
Thank you. Thank you for having me again.
Absolutely. And again, just to refresh our audience, you are focused on anti-aging and regenerative medicine, which we had to talk about for sure, and cardiometabolic and functional medicine, correct? Wonderful. So the last time you were on the show, we sort of, talked about different advancements in pharmacy, and you are sort of state-of-the-art kind of thing right out there. So before we get into this fun stuff that I found and all kinds of questions that I have for you, is there anything that has happened since you've visited us here at Off the Cuff that you want to share with us?
Nothing, very different. Just really been traveling and lecturing. I always say, everybody wants the fountain of youth per se, and I don't know if we can anti-age per se, but I always say I like the term age management, because I think we all can do a variety of different things: lifestyle, stress reduction. And sometimes I should listen to my own advice, right? But it's been, I think personalized medicine is the wave of the future, and I've been so busy, trotting the country and the globe, really lecturing on personalized medicine, genomics, and I think it's just such an exciting time where now we can really tailor-made most treatments for the unique individual, because one size does not fit all.
Right.
And we've been saying that for a while. Even just more recently, a study just was published how, everybody will always say take an aspirin a day, right? If it's a baby aspirin or a full aspirin. And now the study just came back where personalized doses of aspirin for a variety of different outcomes to prevent, let's say, heart, cardiovascular events or heart type stuff like heart attacks, strokes, things like that, is based on gender dosing and also weight dosing.
I was just going to say the weight.
So exactly.
Makes a big deal.
So a lot of times, again, like a 100-pound person doesn't need the same thing as a 300-pound person per se. So it's just really exciting times to see. I've been teaching personalized medicine, and now that's really kind of the new term that we're using instead of functional or integrative or complementary, a lot of different buzz terms that you've heard through the years. And now really the community is coming together, all kinds of different societies and communities, to call it personalized medicine, because truly that's what it is. It's knowing the individual genetically, and then what we call epigenetics. How does the environment turn your genes on or off? And then how do we personalize to that individual human being? Because what I need from anything, whether it's aspirin or hormones or different medications, is very different, based on genetics, epigenetics, weight, metabolism status, all that.
And your body's reaction to whatever's coming into it as well.
It's very different. So it's just exciting times. We've been teaching this for the past 25 years.
So people are just getting
now,
the idea.
It's in mainstream. They're talking the talk and starting to walk the walk. So it's just really, it's just very uplifting and
sure.
And happy.
I mean, personalized medicine makes sense because you're right. I mean, when you're talking about an individual, and they say no individual is the same, right? So you one size does not fit all. If I take 2 aspirins, it's going to affect me differently than someone that would be, maybe 90 pounds or what have you.
Yeah.
So that makes a big difference.
And that's why I think sometimes maybe adverse drug reactions, because,
right.
Drug misadventures, what we call the term misadventures, if you will. And that's either medication errors, dosing, drug interactions, drug supplement interactions. It's the 4th leading cause of death in the country. So hopefully, and we hope that, I think if we personalize more, obviously drug errors are drug errors in all health systems and provider offices and pharmacies. We all do all kinds of things because, of course, you never want to make a mistake, right? So, everybody does their best not to make any errors. But I think once we individualize and personalize, I do think we can reduce, some of the drug interactions, the adverse reactions, hopefully, because then we will give the right medication to that person at the right dose. and if they're the appropriate candidate for it, because not everybody is a candidate
So
for
how
certain
do
meds.
so how do we test for that? I know everybody's genetic code is different. Genetic code is extremely expensive to create for each individual. So what are we doing in terms of advancement to be able to make that reachable for everyone and to be able to personalize the medication without the huge testing and the evaluations and everything that's necessary to get that particular genetic code.
So the good part is the cost is coming down.
So there is a good part.
So I've been doing, I would call genomic or pharmacogenomics, right? Which is really knowing the person's ability. How do they metabolize certain drugs or toxins, right? And we've been doing that in certain clinics for about the past 15 to 20 years, right? The problem is it was so cost prohibitive to really do it on a larger scale and hopefully eventually on a mass scale for the whole country. Because I really think, the science is advancing, the knowledge is advanced. We have definitely much better guidelines now, about certain medications and who the right person is and who should receive them and who should not. Some stuff is still being worked out, studied, but definitely we have much more definitive guidelines now, especially what I call the neuropsychiatric drugs, right? The antidepressants, anti-seizures, some of the heart medications, things like that. We have much better knowledge now based on your genetic makeup who should get that medicine and who should not. Are you going to be a slow metabolizer? And if that's the case, that's okay. That doesn't mean we shouldn't give it to you, but it probably in somebody like that, they would require lower doses. Somebody that's a higher metabolizer may need higher doses to get the same efficacy. Where some people, if they don't metabolize at all, it can be toxic to them and possibly even deadly. So, the opioids is very highlighted obviously around the country now because opioid induced deaths, respiratory depression, overdoses, things like that.
Let's talk about the mental health medications.
Yeah.
There's a lot of different types of mental health in regards to you have bipolar, you have depression, you have these different kinds of things. So what are the drugs of choice, I guess, in regards to maybe healing or addressing somebody that's bipolar?
Yeah. So there's a lot of different things. So there, anxiety,
so what are
depression,
the things that
bipolar,
are now
depression.
Out?
So there's a lot of different drug classes, but really, again, we always try to teach whole body care, if you will, or lifestyle care and stuff. Because sometimes people could have anxiety and panic because their adrenals are a little bit, everybody swims in cortisol baths, I call it, right? Everybody's stressed 24/7 nowadays. Panic, anxiety, sometimes that could be diet related because if people are eating sometimes the wrong food for their body, and if they have kind of more an intolerance or allergic reaction, so they could have, allergic reaction, okay, the type that closes your throat, so you know exactly that. Or sometimes it's called an intolerance where it can create a lot of havoc, but people may not know. Sometimes seizures, even as significant as seizures, stomach issues, celiac disease, everybody knows with gluten stuff. But because of that, they cause a lot of brain dysfunction. And, we always say happy gut, happy brain, truly, and so when your gut is happy, it's healthy, you don't have what we call permeable or leaky gut syndromes, you're eating the right foods, you don't have all this inflammatory stuff that your body's attacking because it's the wrong food for you. That can create a lot of havoc even, and sometimes people do exhibit that as bipolar or depression or panic or, things like that. So, definitely addressing all these things. In Europe, they use a lot of supplements and vitamins. So, for example, there's something called L-theanine. It's an amino acid from green tea. And actually in Japan, it's the most prescribed anti-anxiety, if you will, medication, right? Kind of like similar to what we use here, the benzodiazepines, kind of like the Valiums of the world or the Clonopils. They're really for short-term therapy. They should not be used for a long time, but unfortunately you see it. Sometimes patients are on it for years. Or what we call...
I see a lot of patients on lithium.
Yeah. Well, that's for bipolar, at least mostly, or, manic depression, depressive type symptoms and things like that. But lithium is a membrane stabilizer, and so it really helps with regulating brain chemicals, stabilizing the brain a bit better. So you see we use it very commonly in bipolar disorders. Actually,
is it effective?
So absolutely, in some people it can be very effective. But lifestyle modifications, sleeping well, addressing adrenal type stuff, fish oil has been shown to be helpful in bipolar. Magnesium is very calming to the brain. So sometimes, really it's all additional tools to learn. Medications are absolutely great. They save tons of lives. But sometimes it's nice to incorporate the overall, because the medications can be much more effective also that way. Sometimes you'll see. So lithium may take them so far, but if they sleep better, they eat healthier, they take some targeted supplements, the medications can work really much better. So actually in the old days, 7-Up used to have a little bit of lithium in it, very low doses, called lithium orotate, and that's why it was called 7-Up, because it made you happy and stuff.
I didn't know that.
And so the funny part is lithium is a trace mineral, right? We get it from the soil. And I think maybe sometimes because of the farming technologies and other things, I think sometimes we're not growing everything either in real soil or good soil, if you will. So I do think we are missing a lot of these happy trace minerals, I call them, right? I think if we did lace the water with a little bit of lithium, or like maybe the 7-Up like the old days, I do think maybe that's why they were much happier societies back then, right?
Go back to the old 7-Up.
Right, yeah, and stress. So absolutely, I think, the medications are great for certain, anxiety, depression. So we have what we call the SSRIs, the Prozac or fluoxetine types. We have what's called serotonin norepinephrine reuptake inhibitors, the SNRIs. We have sometimes we use for mood lability the anti-seizure medications that are used also for stabilization. Some of the antipsychotics are used.
Now, the FDA approved for epilepsy, approved the CBD
oil. Yep.
Oil. So how is that affecting everything? And is our pharmacists sort of moving towards that rather than the seizure medications that are normally prescribed?
So it really depends. Again, that's where the personalized, individualized approach. Because that's why I've always been fascinated with the brain, and I've always taught pain management, neurology, and things like that. Because truly, no two patients do the same exact things, because everybody's brain is so different. But really, everybody's body is so different, right? So absolutely, are these, the CBD oils, have they been life-changing in some patients? Absolutely. I mean, you see these kids, they were having, 50, 100 seizures a day. They went down to nothing, right? 1, 2 seizures a day, and if any, and some kids, they didn't do anything to, right? So it depends on what's triggering, whether it's the seizure, the depression, the bipolar in that person. And it could be very different. So again, in seizures, you have kind of brain chemical balance. Again, it's all about the balance, right? So you have excitatory and inhibitory chemicals, right? So in seizures, we think, okay, there's too much excitation and not enough inhibition, right? And that balance is off for that person. Now, the cause of that is multifactorial, right? That could be from, obviously the brain wasn't formed correctly, electrolyte abnormalities, different diseases that make patients more predisposed to seizures, things like that. But are CBD oils appropriately, in patients for seizures? Absolutely, especially if they're CBD receptors, because it's a calming type receptor. So if it's the missing puzzle, missing piece of the puzzle for them, and boy, when we bind to that receptor and we really just calm it down, it's literally magical for some people. But that's why in some patients they may use it and it may not do much, because that wasn't the missing piece of the puzzle for them, at least.
No, absolutely. I had a guest that had epilepsy and was having 50 whatever seizures in just a few month period of time, and was on the CBD oils. And then I asked her, she was on there for 2 years, and I asked her, how many seizures have you had? And she said none.
Yeah.
Since then. And that was just like That took me from, oh my God, marijuana, absolutely not, to, oh, okay, so this works.
Yeah.
And I had a neurologist on the show as well that is very much into that. He's at Beaumont, but he's really charted way new territory, and working with his patients where they're sort of leaning away from the pharmaceuticals and from the the medicines, the drugs kind of things. So do you see a future in terms of pain relief and this whole movement, rather than going towards the opioids and sort of moving away from that with this particular kind of new medicine, I guess I would call it?
Well, I think our new approach to pain management, and I think to disease in general, has to be much more inclusionary.
I think we're going back to the more natural,
the good old days, per
the good
se,
old
right?
days, right?
Well, and again, medications are phenomenal. They save so many lives and stuff. But the point is, we do need other approaches. So, for example, pain, it's not, and part of it is, we probably iatrogenically caused a lot of this, right? Because we're taught, well, okay, you have pain, you use the Motrinate type or ibuprofen, or you got opioids, and isoniazid per se, right? And then in between, we have some of the anti-epileptics, the mood drugs, things like that. They work on pain pathways and things like that, right? So I think, with our approach to pain management going forward, I think has to be much more expanded. We have to look at other modalities and be inclusive of more modalities, but also our science led to that, right? We understand fibromyalgia a lot better. We understand CRPS. We understand neuroinflammation now a lot better, and how that contributes to the propagation of pain. We've learned about part of the brain called the limbic system, and how we literally have to unwind it from learned pain per se. So part of it, it's science and evolution, right? We just learn more, so we get smarter. And now, how can we turn
everybody's
that
getting smarter though? You are, and you're learning more, but we need to spread that knowledge.
Do we need to get away from opioids as kind of our one or two single sources of pain management? 1,000%, yes, because we see what's going on out there, right? We do have to expand the tool shed, as I call it, right?
And people that are on opioids, I mean, they can be addicted from 1 to 2 to 3 doses of that, and that is really scary.
So I think we also have to better define addiction versus physical dependence, right? Because you hear the terms very interchangeable, and so addiction is a disease, right? So this is the patient that, they're forging prescriptions, they're breaking into pharmacies, things like that, because they have to have that fix, right? Now, physically dependent is different. So meaning, if they don't take it, they start having some withdrawal side effects, right? So their heart starts beating faster, they're sweating, they feel a little bit edgy and anxious. That's physical dependence. So addiction is really a disorder, right? And different like that. So absolutely, can some people become physically dependent on them after only couple doses or 3 to 5 days of use? Yes. In the old days, honestly, we used to think, no, that could never happen. It's only after long term. But that's not true, because again, it just depends, I think, the receptors, how they bind to them, how they metabolize it. That's why we're, with genomics and pharmacogenomics now, we really should identify that before we provide pain prescriptions, because I think we can be smarter also about who might be more prone to respiratory depression, or what we would call overdose, right? Because sometimes patients, they don't necessarily go into stupor and sleep in coma from overdoses per se. Sometimes they're normal doses that are too much for their body, because either they're not metabolizing it correctly or as quickly, it's building up on their body slowly over time, and then boom, we shut off the rest. There's respiration is shut off, or they're very cognitively, declined, they're stuporous, things like that. That's why I think personalization, when we know some of the pharmacogenomics about that patient, we can just be much smarter about what might be. So let's say, God, yes, they need an opioid, right, for whatever reason, but we can be much smarter about which opioid may work better with their body.
How do you feel that the physicians' offices and the doctors, are they up on all this new technology, or is it same old kind of thing?
Well, same old. I mean, in some areas, absolutely, it's same old, right? Medicine evolves, medicine changes. We all have to do our job. if you wanna just learn what you learned in school and get out, you should go in the clothing business, right? Not in medicine, because medicine evolves on a daily basis.
Continuously evolving.
And we really, you have to stay up on top of things. You have to read. You have to go to new meetings, information, learn the latest and greatest, read, because it evolves so quickly. But we know sometimes the normal cycle of adaptation into mainstream is anywhere from 15 to 20 years, to change in things. Part of it is we have to be cautious. We got to make sure, yes, that initial data that's sprouting out, if you will, well, because we get a lot of fads in any industry, right? So you always have to make sure that it's logical, it's systematic, it's well studied, and yes, multiple studies have found the same stuff. Then you go, okay, I think there's something here. Now let's look at adapting it into big stream, if you will, and educate and re-educate the population per se, right? And that's the providers, the medical community, and also the patients, right? It's really a bi-directional educational effort. So with pain management, I think, and now I think everybody realizes that, right? Everybody's, I'm traveling so much lecturing on, total pain management, total body pain management, right? What are different approaches that we can utilize? What are different medications, supplements, vitamins, acupuncture? Same thing in psychiatry, right?
Absolutely.
Cognitive behavioral therapy, emotional freeing techniques, really good data on it that sometimes I don't think we take advantage of. Part of it is, I think patients drive that, right? Everybody wants the pill fix, right? I'm depressed, I don't feel good, give me a pill. And if they leave the doctor's office and if the doctor goes, well, you have to sleep, you got to reduce your stress, you got to eat better, you can't, drink 17 pops a day,
exercise,
a pot of coffee, you got to exercise, you got to smell the air, blah, blah, blah. And then come back in 3 months. And if you're not better, we'll try maybe a medication or something. They look at you, right? Like, I'm sorry, no, I want it fixed now, right? So part of it, I think patients have to also really try to embody not just, the quick pill fix, because I think nobody has patience to, sometimes it takes them 20 years to break the body and they want it fixed literally in 2 minutes, right?
Oh, absolutely. There's a couple of things I wanted to really talk to you about. I researching for this show, I came up with something that is called edit embryos, where they can actually genetically edit the embryo to avoid diseases that may be inherited, like cystic fibrosis or hemophilia. I mean, that technology is like, that is like sort of sci-fi kind of thing.
Yeah.
So how close are we to that, or is it actually happening? And I mean, I that blows my mind to even think that's a possibility. Well, and are we sort of, dabbling in an area that maybe is a little bit scarier than, just science?
That's a full loaded question.
I know it is. Go for it.
So, well, I mean, I think you can also, when you look back, right, and people do a nice job of that, you look at the evolution of medicine, right? Before it was a lot more kind of natural medicine, homeopathy, things like that, right? Then we had the advent of pharmaceuticals, right? And that's great, and they save a lot of lives, Going forward, stem cells, right? I mean, and there's a lot of debate about that, right? Ethically, scientifically, how do you adapt it? In other parts of the world, they've been doing stem cells for 20, 30 years now, right? With very good results, very well published, So I do think the next era...
But stem cell is like taking a situation that's already there and trying to... So it's almost like medicine and trying to come up with a solution.
So it's a different tool of medicine, right? So instead of a pharmaceutical is...
But changing the genetic code...
Can I take your, So with stem cells, right? So that's the disease now. They're looking at natural killer cells or NK cells, cancer, because can I just teach your body to fight it better, right? Can I just make this totally robust immune system? Immunotherapy, targeted therapies. So now, we had the natural stuff, then we had pharmaceutical. Now you see our technology is much more what we call immunotherapy targeted or monoclonal antibodies, right? I go and attack the bad guy, if you will, and kind of take it out.
So that's what monoclonal.
Monoclonal is like, you have a lot of like what we call TNF or tumor necrosis factor. It's an inflammatory marker. I'm going to go and just gobble it up and get it out and block it per se, right? So some medications work like that, targeted immunotherapy in certain diseases in cancer. So that's kind of like really where the era of treatments is moving. Next, I think we are getting into stem cells, right? So that's kind of like, can I make what's there much better, decrease degeneration, right? So we have good data on stem cells, at least in orthopedic type stuff, regenerating cartilage, helping bad knees, shoulders, things like that, right? And a bunch of other diseases that really the FDA wants to kind of put under investigational research protocols and continue to, assess the science and stuff, even though in many parts of the world, as it's been around for, now the new thing is what's called this like CRISPR technology or CRISPR technology. So it's gene slicing per se, right? We were actually just having that discussion yesterday. I was lecturing in Lansing, and one of the providers like, hey, what do you think of this? Too, because everybody's talking about it, and so it's basically exactly like, where the genetic hiccup is, because now with technology, we are able to unravel your whole gene, right? Anybody's gene, not just yours.
Well,
per se.
I mean, they say that if you wanted to have a baby, that you could actually
Right.
blonde hair, blue eyes,
exactly.
or brown
So-
hair. I mean,
so to me, that's aesthetics. That's not what this should be used for, right? I don't know.
But
that's
I mean,
a
that
higher being and a
technology is
higher
there.
call.
That
but
technology
they
is
can,
there. So
and I
this is
think
like a-
will we have people that will abuse it?
right.
Unfortunately, yes. Some people, I
Sure.
think, yeah. Oh, and they'll start clinics. Oh, if you want the blonde baby, the blue eyes, the tall, the handsome IQ of 190, come to our clinic and we'll make it
Yeah,
happen.
see,
right?
that's-
but so for diseases,
that's totally different than this. So this
right.
is a
but this is for
step
diseases,
forward.
right? So we know certain genetic diseases like cystic fibrosis, hemophilia, beta thalassemias, and a bunch of others that we
Sure.
can continue to rattle off. Those are, they occur because of a genetic hiccup, if you will, as I call it, in the code. So their technology is, it's called the CRISPR technology, CRISPR-9, I think what they're calling it. Exactly. Their thought is you go and slice that off, the bad hiccup, and put the good hiccup in there, and then replication wise, then you'll start making the good stuff, right? So you remove that disease because you've removed the hiccup per se.
wow.
And so, stay tuned. I think, again, like stem cells, there's going to be a huge ethical and scientific debate about that, right? That's kind of what I see that's going.
Definitely stay tuned. We have 2 more minutes, but I wanted to go through sleep apnea. Maybe we can use 1 minute of that.
Yeah.
I know that there's a lot of different things that are happening and a lot of improvements. And now they're talking about an implant that could help sleep apnea. Do you know anything about that at all?
So I don't know if I'm very familiar with the
Okay.
implant, but there's been a lot of different things. I mean, obviously, historically the CPAP
Right.
machines, the BiPAP
Horrible.
machines, surgery, much more aggressive, obviously. Now we have, dentists that are specializing in sleep apnea, and they can do certain mouth devices or guards, if you will, that will really help with extending the jaw and things like that to open up the airway much longer and stuff. So yeah, I'm not really very familiar with that implant, but yeah, I will have to research
it was
that.
like amazing when I was when I was
Yeah.
reading today. Also, really quick, diabetes. Now they're talking about artificial pancreas.
Mhm. I mean,
How does
thank
that
God
happen?
it's coming. Well, honestly, that's
Can
been
we
in
actually
development.
create
Yes.
a part of a human body that's actually functional within our
Yeah.
body?
Well, actually, now with 3D,
not natural?
Well, with 3D printing technologies, they're
Okay.
actually looking at making organs on a printer per se. So actually the artificial pancreas, it's been in development for about 25, 30 years now. So it's a long time coming. And so basically you're going to have a glucose meter that's constantly measuring glucose, and an insulin pump that's going to basically dispense insulin based on the reading of the glucose.
So that'll basically get rid of dialysis
Well, I mean, it's going to be
kidney?
implant, well, not dialysis, because that's part of the disease if it occurs and stuff, right? Because unfortunately, if people continue to have bad
Right.
control, it can cause bad kidney disorders, as you know. But more, it will replace, the injections, the constant pokes, right? Because people, they poke, they
Right.
measure sugar, then they adjust either insulin doses or whatever, especially in type 1's kids, you know what I mean? So that's going to take a huge burden off parents, patients, because basically the poking and measuring is going to occur continuously now with this artificial pancreas. So it's going to go, okay, your glucose is X. You told me I should give you this much insulin, right? So it's going to be a pre-programmed organ, and soon these printed organs. So that will be very interesting to see.
Well, there's a lot more that we can talk about. I know you're coming back in September,
Yeah.
so we'll talk about cardiovascular disease,
Yeah.
which is huge, and the flu season is coming
Yeah,
up.
it's
So I know
coming
there's
up.
different things that are happening there.
Absolutely. Start washing your hands now, everybody.
Absolutely. Dr.
thank
Sahar
you
Swidan,
always.
thank you for being here, and thank you all for being with us on Off the Cuff. I hope you got some wonderful information, and keep healthy, and we'll talk to you again in September.
Soon, absolutely. Thank
See
you.
you all soon.